In this next part of the compact echo course, we will talk about also very important views, the subcostal views. While the subcostal views you can reach, of course, subcostally, you need to place the transducer below the xiphoid or the rib cage and scan the heart from below. Always remember, the liver is your window to see the heart even better. There are no bones, no lungs who can block your field of view. The marker is oriented to the left of the patient if you're looking for the subcostal 4-chamber view, of course in a cardiac preset with the cardiac transducer as well. The patient is in a supine position and it's an optimal view for the intensive care unit, emergencies, emergency departments, obese patients, also COPD patients. You can use this view if the left lateral position is not always possible or you simply have bad image quality in the other views. This is the best view for pericardial effusion and also to measure the right ventricular wall thickness. It should be a part of all of your echocardiographic exams, and basically you can perform almost a whole exam from this position. Important, of course, is the transducer handling to know and to visualize the standard views. So starting off with a subcostal 4-chamber view, you see the left ventricle, the right ventricle. Here you have the right ventricular free wall, sometimes inferior wall to see. Here is the space which can show pericardial effusion, the right atrium, the left atrium, and of course also the valves. In the normal B-mode imaging, this is how the heart should look like. This is the right ventricle. Here you have the wall of the right ventricle. Here you can measure the thickness. You don't see any kind of pericardial effusion in this patient over here. This is the tricuspid valve, the septal leaflet, and the anterior posterior leaflet depending on the angulation. This is the left ventricle. There's a little bit of foreshortening, of course, from the subcostal approach present. The mitral valve, anterior and posterior leaflet, the left atrium, seen here as well. So when you're below the xiphoid process, you can use, as said before, the liver as your acoustic window. So you will have sometimes superb image quality by means of echocardiography. In the subcostal 4-chamber view, you should see the 4 chambers of the heart. Sometimes it's not that easy to see immediately. It could be also a 5-chamber view, or it could be a little bit of rotation. Then it would look a bit different. But overall, you can see, at least to a certain degree, how the left ventricle and how the right ventricle works, and if there are some severe valvular pathologies. Furthermore, this is the optimal view due to the angulation towards the transducer to visualize the interatrial septum and if there's probably some shunting present. Furthermore, as said, you can evaluate for pericardial effusion. A pericardial effusion is actually present when there is 4 millimeters of echo-free space, so free fluid, around the right ventricle in and diastole. So that's very important to really differentiate a normal collection of fluid from pericardial effusion. This is now such an example where you see pericardial effusion all around the right ventricle, also the right atrium. With the left heart, it's harder to see in the subcostal approach, but the right ventricular free wall, so the right ventricle overall, is the low pressure chamber. So if there's any hemodynamic relevance, you would see it primarily in the right heart, so first the right atrium and then also the right ventricle, and it would be compressed during end diastole. This, in this case, is not present, but this is a case of pericarditis. You see here the right ventricular free wall, tricuspid valve, mitral valve, the left ventricle, and the atria as well. In this loop, you do see a dilatation of the atria. You see mitral annular calcification, also a small degree of pericardial effusion, and a reduced right ventricular function. Be aware that from a subcostal approach, you always have to be careful about the angulation and the actual function you might see in the ventricles. So there are some pitfalls, but still in a clear case, very often you will figure out what right ventricular and also left ventricular function looks like. In this case, you have a reduced right ventricular function. You can see it over here, even though it's an image where the transducer is being tilted and moved a little bit, you can also see that the atria are definitely enlarged. You see here the aortic valve to some degree. So approximately here is also a 5-chamber view, subcostal 5-chamber view. And you do see that the left ventricle at least appears dilated and definitely shows a reduced function. You also see this bouncing motion of the septum, which also points towards elevated right ventricular filling pressures. So overall, only with this one view, you can get a lot of information about this patient who actually is not feeling that well and was decompensated. Another important structure to differentiate is epicardial fat. So here we have free fluid and another thicker layer. This specific patient actually had a Dressler syndrome. So you see this pericardial effusion, it's definitely not large, but this patient had an intervention, cardiac intervention, and after 3 weeks presented with fever, chest pain, fatigue, and also dyspnea. So in combination with this imaging, the diagnosis of a Dressler syndrome was established, and after treatment, the patient felt way better in a very short period of time. In this case, you do see a patient with pulmonary hypertension. You do see that the left ventricle is rather small compared to the right ventricle. If that would be a short axis, that would also be called D sign. So also in this case, you see this shifting motion of the interventricular septum towards the left ventricle away from the right ventricle. In this case, the right ventricle is the high pressure chamber, also compared to left ventricular pressure. So the right ventricle is dilated, definitely reduced in function. You can see it here that the overall contractility is reduced, and there is a severe case, I would say, of right ventricular hypertrophy. So you see the right ventricular free wall where you also would measure, and the right ventricular free wall is almost as thick as the interventricular septum, so around 8 to 9 to 10 millimeters. So it's definitely thickened. Here you have another rather interesting case. This is a patient with coronary artery disease. How can you assume that this is coronary artery disease? Well, here you see the basal parts of the interventricular septum. They're definitely thin and hyperechogenic, and of course, in the overall echo, you saw wall motion abnormalities, scars, and also this patient had a history of coronary artery disease and also had a STEMI just a few weeks before. Now you see in this patient an acute coronary syndrome, and overall left ventricular function was probably 30 to 35%. What you cannot optimally see in this view is that there's also a mitral clip present, so you cannot really see this, but you see a small iatrogenic atrial septal defect. You see here is a bulging of the interatrial septum, so this is the left atrium, the right atrium, and the septum is pushed towards the right atrium, which is per se a situation which can occur because overall left ventricular pressures and left atrial pressures are higher compared to the right heart. But what's quite intriguing is that there is also this small iatrogenic atrial septal defect because you need to perforate the interatrial septum to place the mitral clip. Furthermore, a quite interesting finding is this structure here. So this is most likely a Eustachian valve. A differential diagnosis are retichiari, so just anatomical structures which you can see in echocardiography. Going back just for a second to this atrial septal defect, you see that there is a shunting, so this small flare and color Doppler from the left atrium with the higher pressures, also explained by coronary artery disease, and this case of heart failure with reduced ejection fraction from the left atrium to the right atrium. To even more optimally visualize, you can even use color M mode. So it actually doesn't give you that much of additional information by means of how large the atrial septal defect is. We already can assume that it is not very large, also because it's an iatrogenic ASD, so this won't be a problem by means of volume overload, but you can see quite nicely how the shunting looks like. So this is the small iatrogenic ASD in color M mode. Moving on subcostally, we discussed before, we can also see the fifth chamber, so the aortic valve, the LVOT seen over here and here the aortic valve. You simply have to tilt more, so the beam of the transducer, or the transducer is looking more cranially. And here you see that there's the aortic valve. You lose a little bit of sight of the left atrium, but you get a very nice view of how the valve is opening. Also in this case, you can take a look if there's pericardial effusion present, and you might think that here is a bit of free fluid. Overall, in this case, it's definitely not pathological. So also in this view, you can evaluate the heart if there is a relevant pericardial effusion present. So this specific patient presented with dyspnea and more signs and symptoms of heart failure. And there is a very, very localized pericardial effusion around the left ventricle and also the left atrium. You can see it even better in this 5-chamber view. So this is even a little bit of an over-rotation from the 5-chamber view. And additional features here include this septal bounce. So there is a septal bouncing. This actually turned out to be constrictive pericarditis. And the first views you can get in this patient already from a subcostal approach, which show you, even though it's in the far field, a localized pericardial effusion and this weird movement of the interventricular septum called septal bounce. So this is a point of care setting. This patient had several infections, also tuberculosis and a pericardial effusion due to the infection, and indeed ended up having constrictive pericarditis. Now there are some more views we have to take a look into. So the subcostal short axis view, for example, is something you do not want to miss. From the subcostal 4-chamber view, you simply rotate counterclockwise so that the mark of the transducer points towards the left shoulder of the patient. And if you're in the right imaging plane, you can get a subcostal approach from the short axis. So this looks like the parasternal short axis, just you perform this view from a subcostal approach. You see the tricuspid valve, the right ventricle, RVOT, pulmonic valve, and here the pulmonic trunk and even the pulmonic arteries. This is an optimal image where you can see the interatrial septum, the left atrium, the right atrium, the tricuspid valve, the right ventricle, the RVOT. Here you see the pulmonic valve, the pulmonic trunk, and the right and the left pulmonary artery. So with this view, you can have a really nice overview. You even see that the aortic valve is tricuspid. You can even measure here, for example, with the pulse wave Doppler, the pulmonary acceleration time. So this is an important view, especially if the parasternal views are not possible or if they are not that good. So from this subcostal approach, you really can differentiate that the aortic valve is tricuspid, the right coronary, the acoronary, and the left coronary cusp is seen. If you have a pulmonary embolism, you can sometimes even visualize it directly from this subcostal approach. Additionally, when you start at the aortic valve, you can move and tilt the transducer. So it's actually more the tilting from the aortic valve towards the apex. So as you would tilt the transducer in the parasternal short axis, you can tilt the transducer in the subcostal short axis as well. You can move from the aortic valve to the mitral valve, visualize as seen here the tricuspid valve, the pulmonic valve, the pulmonary arteries, the right ventricle, the interatrial septum, the RVOT. You can see if there is pulmonic stenosis present, pulmonary regurgitation. You can use it for shunt calculation as you would do it with the QPQS in the parasternal views and for the left ventricle with the apical views. You can even look for wall motion abnormalities if you have the optimal view towards the left ventricle from the subcostal approach. It's simply the same as you would do it parasternally. Here are some examples where you see a calcified but not stenotic aortic valve. Also, the aortic root seems borderline. There is an extrasystole, ventricular extrasystole, the RVOT, the pulmonic valve, and this dilatation of the pulmonic trunk, and the right and the left pulmonary artery are also dilated. The left atrium from this approach also seems dilated. Of course, you need the other views to really quantify, but again, you get a lot of information out of these views. You can use M-mode as well in this situation. So you can even see the aortic box in the center of the image, and you can even visualize the tricuspid valve. So from the subcostal approach, you can do basically what you want. The one important thing you have to be aware of is the angle. So in this case, you want to measure the pulmonary acceleration time and the signal of the RVOT and after the pulmonic valve. You want to place the pulse wave Doppler, but if there is the angle which is not optimal, you will not get accurate signals. So always be aware that the angle should be as optimal as possible, because if you do not have the optimal angle, the signals you get will be simply not true. In this case, you have truly a dilatation of the aortic root. Still, this is a subcostal short axis view. And if you tilt the transducer caudally, you do see here the left ventricle, here the papillary muscles. Before there was even the mitral valve. So from the mitral valve towards the left ventricle, starting from the aortic valve, you can visualize all the structures of the left ventricle from the aortic valve, LVOT, to the mitral valve, to the papillary muscles, to the apex. Also, additionally, you can see that the tricuspid valve sometimes is even shown tricuspid in this view. And also you can see more structures of the right ventricle. Sometimes it is even possible, if there is an optimal alignment of tricuspid regurgitation, to measure the pulmonary arterial pressures. Very often that won't be possible because, as in this case, the continuous wave Doppler is not optimally aligned. So it's always a guessing game what you're actually measuring. But if you have the optimal signal with an optimal curve, you can even try to measure it from this subcostal approach. Focusing on the left ventricle, you see those two loops over here, where you again can look for example, wall motion abnormalities and overall radial function of the ventricle. Continuing our rotation from the short axis view, where the marker points towards the left shoulder of our patient, we rotate the transducer so that the marker points cranially. And then you have the view of the IVC. Of course, the IVC is a little bit more located towards the right side of the patient, whereas the aorta is normally a little bit more localized towards the left side of the patient. Here I have such an example where you optimally see the inferior vena cava, here the right atrium. Here you see the collapsibility while this patient is inhaling. So the collapsibility is also very important for volume status, but this is the topic of the volume status dedicated chapter. Why is it important by means of right atrial pressure? Well, again, it's the collapsibility. So if it's not collapsing at all, the right atrial pressures are normally higher compared when it's really nicely collapsible, as in this case. Also, the SVC can be visualized. The SVC is a continuation of the IVC. And of course, you can take a look if you see a right-sided pleural diffusion, which already gives you a hint towards what you will scan when you're performing lung ultrasound. In this case, we also want to focus on this artifact. You see here the heart, this trivial pericardial fluid. So this is not a pericardial effusion, simply normal amounts of free fluid. You see the inferior vena cava, which also doesn't look pathological. This is the liver, the portal venous system. And here in the area where you would suppose that there are lungs, you do see it's like a second heart. Of course, it's not a heart. It's here this hyperechoic line, which is representing a mirror. So this is a mirror artifact. The pericardium, the lungs per se, so the pleural line and the diaphragm, they can act as mirrors and create those artifacts where the machine simply thinks that the structures from the scanning above this highly reflective zone continues into the depth as well. But this is not pathological, it's simply an artifact. Another structure, we already talked about it briefly, is the Eustachian valve. So this is a normal structure you have in the embryological state, so you actually need it, but at some point it's not a real valve anymore. It's just very often a structure you can find which is always connected to the IVC, and it doesn't have a pathological nor an anatomical function. Sometimes in very, very rare cases you can find an endocarditis there, but so far in my entire echocardiographic life, I have never seen that. Eustachian valve you see over here, sometimes it can be really prominent and really large, but it always originates at the IVC. In this case, we have a dilated inferior vena cava and there is practically no collapsibility during respiration. So this is not an intubated patient. This shows hypervolemia. Also, if you take a look over here, there is pleural effusion present, and using color Doppler, you do see this change in red and blue color, even though there is a normal PRF optimized for echocardiography. So this indicates tricuspid regurgitation, relevant tricuspid regurgitation, and also it can indicate elevated right atrial pressures. This is very important when we talk about measuring and visualizing the flow of the hepatic veins, for example, in constrictive pericarditis, but also when we are performing a Vexus protocol. So it gives us already hints about volume status and many other pathologies as well. This is a case, sometimes you see it in echocardiography. It's not something you want to see. So this is a patient with renal cell carcinoma. It was not known before, but what was apparent in this first view of the subcostal approach, you see that the IVC is filled with a mass. So this is a tumor thrombus formation in the IVC in a patient that turned out to have renal cell carcinoma. So this is something you truly do not want to find in your echocardiographic exam. Unfortunately, it happens from time to time that you are the first one to describe this mass. Continuing, in the subcostal approach, we can also scan the liver veins. So we can continue our rotation or we can stay in the same angulation. If we continue our rotation, we can see all the three liver veins. Here's the right, the left, and the intermediate. So there are three, and for the Vexus, for example, you need one who is optimally located towards the transducer to perform measurements. So this is also called the star of the liver vein. So this is the inferior vena cava entering the right atrium. This is the interatrial septum, and then you have the liver veins here. Don't confuse this with a vein. This is actually portal venous system. With the liver veins, you can use, of course, the B-mode image and just sweep through the liver veins to see how large they are, if they are small, normal in size. So approximately in this area, it should be around 7 millimeters. If it is larger than 7 millimeters, there could be congestion. In this case, we do see that the liver veins, all of them are definitely enlarged. And this is the patient with heart failure, the flow backwards, where you see this change in red and blue color, which indicates relevant tricuspid regurgitation and elevation of right atrial pressures. Previously discussed, the IVC continues, or the continuation of the IVC is the SVC. We can use it to see the IVC also. Sometimes in this view you get an optimal differentiation of this hepatic vein, and here the entering of the IVC into the right atrium. This is the tricuspid valve. Here we have the Eustachian valve, a very prominent Eustachian valve, and the continuation of the IVC is the SVC, the superior vena cava. You can look at the collapsibility as well. Like the IVC, of course, the SVC has to collapse, but you get a better delineation of the SVC in transesophageal echocardiography compared to TTE. Showing color Doppler, here's the IVC, the right atrium, trivial tricuspid regurgitation, and the SVC as the continuation of the IVC. We can continue and now move towards the aorta. Continuing from the IVC, we can also scan the aorta. So with the SVC is the continuation of the IVC. Sometimes you still have to rotate a little bit. For the aorta, you simply have to have the IVC in the optimal longitudinal plane and then tilt the transducer more to the left side of the patient, where you would expect, of course, the aorta. Here you have the aorta seen in this image. It's normal in size. You have the celiac trunk, the superior mesenteric artery, here the liver, the right atrium seen as well. So depending which transducer you use and which exam you perform, the orientation can be upside down as well. So it's very important to differentiate abdominal ultrasound from echocardiography. As said, here we have more anatomical findings, the celiac trunk, the superior mesenteric artery, as mentioned before. And continuing, of course, we want to see some pathologies. In this case, you have a severe pathology. You see that there is a membrane. So you have two echo-free spaces. You have here the mesenteric artery, here the superior mesenteric artery, the celiac trunk. And when you utilize color Doppler, you do see you have here two overall possibly blood-filled structures. So this is a case of aortic dissection. You see that the aorta is definitely enlarged. Here you have this dissection membrane. This is the true lumen, the false lumen, and there is shunting in between the true lumen and the false lumen. You also see that there is turbulent flow towards the celiac trunk as well in this view. So to summarize, from this subcostal approach, very often you get a very good glimpse of the aorta, and you should always at least once take a look at the abdominal aorta as well. For the IVC, I want to add one information, because sometimes it's not that easy to see the IVC in this longitudinal plane. You are not entirely sure where you are actually located. Then simply use also a transverse plane. So rotate the transducer that you have a transverse plane and see if the IVC is round and not collapsing, or if it's oval shaped or more ovally shaped and collapsing nicely. So they can also get a lot of ideas and more knowledge of what the IVC is actually showing you by means of volume status, by means of atrial pressures, right atrial pressures in this case. There are some special views I want to talk about, not only the possibility to look at the short axis from a subcostal approach, but also a long axis view. So when you over-rotate and the marker points to the right shoulder, so not like in the four-chamber view to the left of the patient in the short axis to the left shoulder, or the marker pointing towards the heads cranially for the IVC or the aorta, you really want to rotate the transducer until the marker points to the right shoulder. And here you have the same structures as in the peristernal long axis. Again, this view you can use when the peristernal view is simply not possible, or if you need additional information. In this case, you see the tricuspid valve almost, again here in this view, you see all the three cusps. So it's still a little bit off axis, but it's a splendid view of the tricuspid valve. The right ventricle, the left ventricle, here you see parts of the mitral valve, and the ascending aorta you can visualize here, the aortic root and of course the aortic valve opening quite nicely in this case. So already here you can see that there is definitely no aortic stenosis present. So by means of subcostal approaches, it's very important to know that most of the views you can find peristernally and also apically are possible to be visualized in these subcostal views. In the subcostal long axis, of course, you can also use color Doppler, and in this color Doppler study you see that there is mild aortic regurgitation present. So again, we do not see real turbulent flow when the blood is exiting the heart, so the LVOT, the aortic valve. You simply see that the valve is opening nicely, but there's trivial aortic regurgitation present. You can even tilt a little bit more and then you can get more views. So in this case, we have here the tricuspid valve with all the three cusps. We initially see that there's the aortic valve and even larger parts of the ascending aorta. And when you even tilt more cranially, so the transducer pointing cranially, you see the RVOT from this atypical subcostal approach, where you see the long axis view of our heart. Even continue with our counterclockwise rotation and the tilting, and furthermore you can also visualize the pulmonic valve and the RVOT and the pulmonic trunk from basically all possible views from a subcostal approach. So in this 5-chamber view, you can simply tilt more. If you over-rotate, you can also achieve this view. So it's only about tilting and the optimal rotation to get more views of the pulmonic valve, the RVOT, and the RV inflow, outflow view you can find sometimes as well. Now we discussed about the aorta already, but if you are in the 5-chamber view and then you rotate a little bit and tilt a little bit, you can find the ascending aorta again, and even you can visualize the aortic arch. So the subcostal approach is a very powerful tool to visualize many structures of the heart. I've mentioned it several times, but when you focus on the tricuspid valve, you can see that the tricuspid valve has 3 separate leaflets, quite nicely seen in this almost short axis view. So this is a little bit of try and error. So you rotate towards the aortic valve, focus on the tricuspid valve, and then rotate and tilt until you see all the 3 leaflets, the septal, the anterior and the posterior leaflet of the tricuspid valve. This is very important to, for example, localize where the tricuspid regurgitation actually is originating, if it's central or if it's eccentric. With using, for example, a gold color or brownish colors, you can see structures very often even better. And here you have these two images from different angulations. So this is almost a 5-chamber view, but more rotation towards the short axis, where you see that there is the aortic valve. Here you have the RVOT briefly, and all the 3 cusps of the tricuspid valve. In the same patient, when you rotate towards the long axis, here you have the left ventricle, the aorta you see, and here the RVOT, you can again visualize all 3 cusps of the tricuspid valve. So from many views, with a little bit of rotation and a little bit of tilting, you can differentiate tricuspid valve right ventricular structures and left ventricular structures. So by means of orientation, anterior, posterior, and septal, you can see and describe in this view as well. To summarize, subcostal is almost always possible. So also on the ICU, when you are in the emergency department preclinically, you can scan patients most easily. Also, if there are many problems, for example, the patient is intubated from a subcostal approach. When you perform resuscitation, of course, you also choose subcostal approach. If you have tamponade, you can see it best in the subcostal approach. But that's not all you can see. You can see almost everything, almost every cardiac structure you can visualize with a little bit of practice from these subcostal views. But be aware, the measurements are sometimes off. There's always an angle dependency of Doppler, so if you do not have the optimal angle, the measurements would simply not be correct. As I said, it's optimal in emergency settings, ICU with COPD patients who are actually cahectic. Very often only the subcostal views are possible, but then you will have amazing image quality from the subcostal approach, where you have never seen the heart, even a glimpse of the heart in the peristernal views and the apical views due to emphysema, for example. You can ask the patient to bend the legs. That gives a little bit less tension to the abdominal muscles. Very often I actually do not do it in my daily clinical practice. If the patients are obese or they are really muscular, the heart is really, I have to say, deep inside. So use enough depth. You always want to start with at least 20 centimeters from the subcostal approach, and be aware to have enough gel and also enough pressure, but still it shouldn't hurt our patients when you're performing this exam and using those views. This already summarizes the subcostal views of the heart. The next chapter, the next videos will be about some more atypical views and also about the suprasternal approach and why we would use that in our daily clinical practice.